I just want to welcome everybody to In Other Words, Combating Stigma and Transforming Culture Through Language Change. My name is Lori Blockett, and I am the Drug-Free Communities Grant Coordinator working with Wright County Public Health and the Mentorship, Education, and Drug Awareness Coalition, otherwise known as MEADA. This event was made possible by a 5-year Drug-Free Communities grant that MEADA was awarded earlier this year. MEADA and Wright County Public Health, Wright County Health and Human Services as a whole have joined forces to promote and support this event. I'd like to thank the Buffalo School District for providing this beautiful yet affordable space for us to house a safe event. Immediately after the presentation, the event will continue out by the vendor booths. We will gather at the tables to debrief, answer any questions you may have, and have some discussions about this topic. When you exit the auditorium, and actually I would like you to exit in that door right there. When you exit, you'll be handed a packet of information, a folder. So please sit at the table that matches that color of folder when you go and find a table. I'd like to thank Know the Truth for providing discussion guides, as well as all the vendors that are listed on this slide. On September 23rd at 3 p.m., we will have a follow-up webinar to review the information from today and give people an additional chance to get their questions answered. If you would like to get the Zoom information for that webinar or a certificate of completion to hand in for today for continuing education credit, or the recording of the afternoon session, please use the sign-up sheets that are at the MEADA vendor booth or at each discussion table. To give you a little bit more information about MEADA, our mission is to educate youth, families, and the community on the dangers of substance use and misuse by creating awareness and fostering mentorship through sustainable efforts. If our mission is part of your personal or organizational mission, please sign up for the MEADA newsletter at our booth or consider joining our coalition. We meet 6 times per year. It's not a huge time commitment, but we pack a lot into those 1-hour meetings. You can ask any MEADA member, especially the ones that attended yesterday. We packed a lot into 1 hour and 8 minutes. We do believe that we are making a difference in Wright County. I first heard our keynote speaker in May when the CDC sent the Drug-Free Communities grantees a newsletter with an invitation to join an online event addressing stigma for substance use disorder. I have been talking with quite a few Wright County organizations that serve people diagnosed with substance use disorder and was looking for a training that fit their needs. As soon as the webinar ended, I spoke with 2 other people in Health and Human Services who attended, and we all knew that we had to host an event right here in Wright County, and I am so glad we could do so safely and in person. Our guest speaker today is Dr. Ilona Balasanova. She comes to us from the University of Nebraska Medical Center, and she has specialized expertise in integrated treatment for substance use disorders co-occurring with other psychiatric conditions. Her full bio is on the slide, and it's a lot. She is quite accomplished. I almost needed a slide just with her bio on it, but I think that's a great problem to have. Dr. Balasanova has presented and published nationally and internationally on addiction psychiatry education and destigmatizing substance use disorders. In recognition of this work, she was awarded the prestigious American Medical Association Foundation Award for Health Education in 2020. It is my pleasure and honor to present to you Dr. Ilona Balasanova.
Yes, this is on. Wonderful. Well, thank you so much for having me. I'm very excited to be here. It's my first car trip to Minnesota with toddlers. It was great, but we did it, and here we are. And I'm just really excited to be able to talk about this subject, which is so important. So in other words, combating stigma and transforming culture through language change. I don't have any disclosures. And here's the objectives for this brief talk. So we'll define addiction and substance use disorder, and we'll review the related terminology. We'll summarize some general treatment concepts and discuss interventions for reducing addiction stigma and providing evidence-based care. So addiction, it's all around us. It does not discriminate. It is in our communities, but what is it? So the definition of addiction is that it is a chronic brain disease that has the potential for both recurrence or relapse and recovery or remission. It's associated with uncontrolled or compulsive use of one or more substances. And it is also the most severe form of substance use disorder. Now, this definition comes from the US Surgeon General. And I just want to call out your attention to the fact that the use is uncontrolled, right? That is the most important part of addiction. By the point of time where somebody has developed an addiction, they no longer are in control of their use. And the addiction has taken over. Their brain has been hijacked. So oftentimes when we expect them to simply stop, it's a silly thing to expect because it's not possible. Their brain does not let them. So as a chronic brain disease, addiction has the potential for recurrence and remission, meaning that it's something you live with for your entire life, but your symptoms can remit and be in remission for many years, if not indefinitely. So in this way, it really is how we currently conceptualize cancer as well, where you can have a recurrence and then you can go into remission. So it very much is not unlike other chronic diseases that we have. Again, this uncontrolled use despite negative consequences. It's important enough to reiterate again that when somebody has developed an addiction, it is no longer a choice. It is no longer anything under their control. So since we've defined severe substance use disorder as an addiction, right? Addiction is the most severe type of substance use disorder. Let's define substance use disorder. So substance use disorder is a medical illness caused by repeated misuse of a substance. It develops gradually over time. So if you use a drug one time, you cannot automatically become addicted to it. It takes time to develop these brain changes. And the brain changes have been noted on imaging, on scientific research studies over the past 20 and 30 years. So we know definitively that there are parts of our brain that change after we become addicted to substances. So then what is substance misuse? Since we talked about how repeated misuse of a substance can cause a substance use disorder, so what is substance misuse? So this is the use of a substance in a way that can cause harm to the individual or those around them. And now for some substances, any use constitutes misuse. For example, if you use methamphetamines, which are illegal, you are potentially causing harm to yourself, not only to your health, but also legally, right? So just any use of methamphetamine constitutes misuse. However, for legal substances like alcohol, you can use it safely by drinking within the recommended limits, or you can misuse it by binge drinking or engaging in hazardous drinking or in drinking and driving, right? Because all of those can cause harm to the individual and those around them. So you can use or misuse alcohol and other legal substances. So we talked about brain changes, and here's an image of the brain, a very simplistic one, looking at the different parts of our brain that become impacted when we've developed a substance use disorder. Now, most importantly, these brain changes focus a lot on the prefrontal cortex, which is the very front part of our brain. It is really what differentiates us from our other mammalian counterparts. It's what allows us to have executive decision-making. It allows us to reason through an action and then follow through and execute that action. And unfortunately, substance use disorder causes changes that impair our ability to do that. They really impact that prefrontal cortex part of our brain. Then what ends up happening is that we have problems with self-control and decision-making. So we struggle with making good decisions for ourselves, and we struggle with impulsivity and controlling our impulsivity to continue to use the substance. Again, all directly because of the brain changes that have occurred from our substance use disorder. So this is the continuum. According to the Surgeon General, you can start with substance use, which then can lead to substance misuse, which over time can lead to a substance use disorder and ultimately culminate with what we call addiction. And this is the progression of how that happens. So equally important, and maybe more important actually, is what is addiction not, right? We just talked about what addiction is. What is it not? It is not a moral failing. It is not a character deficit. It's not bad behavior. Certainly there could be a symptom of one's addiction. It's also not poor decision-making, although that is a part of it because of the brain impairments. And it is not a voluntary choice, right? Just by definition alone, an addiction means uncontrolled use of a substance. So it's not a voluntary choice to do that. You are compulsively using that substance because your brain is telling you to. So the language of addiction is really important. And as the title of this talk suggests, language is the pathway through which we can really enact so many changes with regard to stigma reduction and stigma education, right? Language is the fabric of our communication. And we each have the power to look at our language and to change our language. So the words that we use to talk about substance use disorders really matter. We just talked about these definitions, these clinical, medically accepted definitions of substance use disorder, substance misuse, substance use, addiction. A person with a substance use disorder, we call that person first language. What we don't want to hear is things like substance abuse, which really sounds like it's criminalizing what we know is a brain disease, right? Abuse makes me think of child abuse or other criminal acts, certainly not a medical illness. Replacement therapy, that's a term you sometimes hear to describe individuals who are taking an opioid agonist medicine for their opioid use disorder. Right? And so people will think, oh, you're replacing one addiction with another, which is completely false. You're simply taking a medication to treat your disease. Calling somebody an alcoholic or an addict or a drug abuser, right? That is the opposite of what we call person first language, because we're labeling somebody. We're labeling their entire humanity with this one problem that they have, right? If somebody's an alcoholic, they're not a person, they're an alcoholic. But they can be a person with an alcohol use disorder. And that truly humanizes that individual and allows us to see them for more than just their disease. More than just being compassionate, there is true science behind the language that we use. Because what we don't think, we do think, right? We are biased as humans, all of us, every single one, myself included. Right? We all have unconscious biases that our brain likes shortcuts. So when we hear certain things, our brain goes through that shortcut to enter a space from which we look at the situation. So when we hear things like substance abuse, we automatically jump to a place of negativity and we view that situation from that lens of negativity. And it's really universal. It holds true for even the most experienced and highly trained professionals. I have several examples of bias in clinical practice. This recent study, which was done at a Harvard-affiliated Boston hospital, looked at 300 of the hospitalists, so the internal medicine doctors taking care of people who are hospitalized, and it looked at their attitudes and their feelings about substance use disorders and the patients who have them. They found that 38% felt that substance use disorder is different than other chronic diseases because people who use drugs or alcohol are making a choice, which again, we know is not true because it is not a voluntary choice. And yet here we have, Harvard affiliated doctors who think that is true. 14% felt that medication treatment using opioid agonists is simply replacing one addiction with another, which is exactly what the term replacement therapy connotes, even though that's not what it is. And this is the most chilling, I think. 12% thought that somebody using drugs is committing a crime and deserves to be punished. I like to think of somebody who maybe has diabetes and poorly controlled blood sugars. If they were eating a piece of cake, would we say that they were committing a crime and deserve to be punished? Certainly not, but that is how people view individuals with substance use disorders. This type of language will impact patient care because of the biases that we have. Our attitudes and implicit bias drive our behavior as clinicians, as individuals working with people in recovery in the community. We are more likely to assign blame to the person, more likely to agree with the need for punishment, and view somebody that is a substance abuser less deserving of treatment than if the same person is described as a patient with a substance use disorder. This study was profound, where they had clinical vignettes and they had healthcare professionals read the vignettes and answer a series of questions afterwards. The vignettes they were given were identical. One called the people substance abusers. The other one called the individuals patients with a substance use disorder. And then they looked at how much you agree and disagree with certain statements, like blaming the person and agreeing with the need for punishment. And so with identical clinical situations, simply calling somebody a substance abuser resulted in our wanting to punish them as clinicians, in our wanting to assign blame to them and finding that they were less deserving of our care and our services. More than just patient care, language impacts clinicians as well. Healthcare professionals in general hold fairly negative attitudes towards people with substance use disorders. They also hold very inaccurate attitudes, as we learned from the other study. These types of attitudes are linked to lower levels of empathy. And we know that empathy and engagement and lack thereof is a huge driver of clinician burnout, which is another epidemic we have amongst healthcare professionals, particularly now in the COVID era, where clinician burnout is all over the place. So when we add in this mix of negative feelings, decreased empathy, and engagement with patients with substance use disorder, it actually results in increased clinician burnout, which subsequently is linked with poor patient outcomes, right? If you have a burned out clinician caring for you, your outcomes generally are going to be worse than if that clinician was engaged and empathetic. So all of this aside, how common are substance use disorders? Well, 1 in 7 people will develop a substance use disorder at some point in their lives. So even in this room, if we were to count off by 7, right, statistically speaking, that is how many individuals will develop or perhaps already have a substance use disorder. It is one of the most common clinical conditions that we have. Although the substance use disorder diagnosis is common, how common is the treatment for it? Well, these numbers are a bit more abysmal. Only 1 in 10 people will actually receive any kind of care or services. So 90% of people who have this medical disease do not get any help for it. So then I ask, how would we react if only 10% of people with cancer receive treatment? Right? I don't think any of us would tolerate that. It seems unfathomable given the amount of money and time and intelligence that goes into cancer research and cancer treatment research, right? But that is what happens with substance use disorders. Part of that is because of this traditional model of addiction. The way that we have historically approached addiction follows like this Peanuts cartoon. So we have Lucy offering psychiatric help. We have Charlie Brown, who is disclosing these very personal feelings, these deep feelings of depression and asking for help. And Lucy tells him to snap out of it and pay her 5 cents, right? And that is exactly how we have been approaching substance use treatment in our country for generations. The traditional approach was based on the now we know inaccurate idea that substance use disorder is acute and curable, right? We know now it is a chronic disease that is treatable. But historically, the priority was always to remove access to the offending drug. The services were time limited, and abstinence was the only goal. So you can't be on medications, you have to be, clean and sober, which again is a pejorative term, right? Clean. We're not saying that people are dirty or clean, right? We're just saying that they are sober or in recovery. So given that history, let's redefine the treatment paradigm. So in color now, we have Lucy, again, offering psychiatric help. Snoopy comes and opens up shop next door at a cheaper cost, which is awesome, and calls himself the friendly advisor, right? Friendly advice as opposed to psychiatric help. How does that differ? How are we now meeting people where they're at? How are we more patient-friendly in this new treatment paradigm? We call this harm reduction. So this is a conceptual and clinical framework that decreases the negative consequences of substance use without necessarily reducing the consumption of substances. So just to repeat that, without necessarily reducing the consumption of substances. It is what many consider quite a radical idea, and yet the rest really feel that it is what upholds respect, dignity, and compassion for the patient. So harm reduction is an evidence-based public health approach. It is strengths-based, so we're looking at the positives, not just the negatives. And it's not one size fits all, right? It's not send you away to rehab, a 28-day program, which used to be the only solution. And it was a cookie cutter solution for everybody. That's not how harm reduction works. You meet the person where they're at in their recovery journey and you stay with them. And they may be very early in their journey and not fully ready to commit to sobriety. And that's okay, because recovery is not defined by abstinence in the harm reduction model. Certainly it can be if that's what the person wants, but by no means do we place those goals onto the patient. There are no progressive steps to complete. So like we're so used to hearing about 12-step programs, there are no progressive steps to harm reduction. And it's not a circumscribed program, right? It's not something that, again, we send somebody away to or expect them to do. It's not cookie cutter. It is 100% individualized to the person sitting in front of you. There's a variety of interventions that are possible, and there's a spectrum of strategies. So one, for example, safer drug use, syringe and needle exchange programs, one of the most evidence-based proven ways to reduce the transmission of HIV and hepatitis by over 50%. It is also a great way to get people engaged into substance use treatment because they are 5 times as likely to enter substance use treatment if they have accessed syringes or needles at an exchange. We have moderation management. So being in a controlled environment, being on maintenance therapy. So medications for alcohol use, opioid use. We have medications that are called maintenance therapy. And of course, abstinence. Certainly a worthy goal, only if the patient wants it to be their goal. And to reiterate yet again, the goals do not necessarily include reducing the consumption of substances. So then what are the goals, right? If that's not the goal, and that's historically been the only goal. Well, we focus on functional impairment, not sobriety. And functional impairment can look different for different people. I like to share this anecdote of a patient that I saw in training who came to me and had an alcohol use disorder, and it was really interfering with her life. She worked as an electrician, and she had gotten in trouble at work because she was drinking in the morning. And she obviously could not work, and they placed her on leave until she, got this under control, so to speak. And I asked her, what are your goals? How would you like me to help you? And she said, I don't want to get into trouble at work. I want to keep my job. And to do that, I can't drink in the morning. And I said, that's right, you can't, because you can't drink before you go to work because you'll get in trouble. And that's what we focused on. We focused on her not drinking in the morning, and that was our goal. Well, we met that goal with psychotherapy every other week, with medication for alcohol use disorder, and then we made more and more little goals depending on what it is that she wanted. And eventually, after working with her for 2 years, she was drinking 1 drink a night and sometimes not even finishing it. So to me, that was a remarkable opportunity to help enhance this person's life in a way that made sense for her and in a way that didn't focus on sobriety at all, and yet completely improved her functioning and her ability to live a more quality life. So evidence-based treatment, a set of services. Like I mentioned with the patient that I saw, there's medications that are available. There's psychotherapy or counseling, which is also what we engaged in, and other supportive services that can help. And that may include other medical services, other case management services, perhaps job training, all of those sorts of things that can help somebody live a more supported life. So medications for addiction treatment. Medications, or MAT, sometimes we call it, it's been shown to keep patients in treatment longer, increasing their chances of a long-term recovery. Most research studies that look at medications, the end point is retention in treatment and survival, right? Because we want our patients to be alive to get better. We can't really help them if they overdose and die. And so not only does it keep patients alive, it increases their engagement, which then again increases their chances of a longer term recovery. Medications also save lives. This was a study out of Massachusetts that showed that Medicaid enrollees that were using abstinence-only opioid use disorder treatment actually had 75% higher mortality than those on partial agonist maintenance treatment with buprenorphine or Suboxone. So 75% higher mortality. That's terrifying to me, that we would offer a treatment where we know that that is what's going to happen, right? Where we know that there's a safer alternative that can help keep these individuals alive. And that alternative is through harm reduction. It is through offering medications when they are FDA approved for the disease the person has. We also have pretty substantial criminal justice outcomes. So individuals on federal probation who are receiving opioid antagonist treatment had a 50% lower rate of reincarceration and a 70% lower rate of illicit substance use when we compare those that were not treated. And this was actually a multi-state study, so it was across multiple states that this effect was found. Individuals with outpatient medications for addiction treatment also had 17 to 27% lower odds of getting arrested since starting their treatment, even if there was previous criminal justice involvement. That is the key. Historically and in general, previous criminal justice involvement is what predicts future criminal justice involvement. So even taking away that risk factor, we still, with medications, had a reduced odds of getting rearrested, which is amazing and allows people to remain in the community, engaged and living their lives. Peer recovery supports. This is another important element of harm reduction. As I mentioned, those additional supportive services. Peer support workers are often individuals with lived experience who may have mental illness or suffer from substance use disorders and are in recovery themselves. and they can offer a role model recovery and provide support across the continuum of care. There are certain institutions where there are peer support workers in the hospital, in the emergency department, that are able to meet with patients and just say, hey, I was in your shoes once. If there's anything that I can do to help, you let me know. And oftentimes that camaraderie and that really low stakes engagement with a peer, somebody who looks, walks, and talks like you, can be much more effective than if a clinician were to tell a patient the same thing. They also meet patients where they're at in their recovery, right? So in the unexpected settings like the emergency department. We also have community self-help groups. So Alcoholics Anonymous, which I don't like the term personally, alcoholics, but it is a term that is employed by the group. Alcoholics Anonymous and Narcotics Anonymous are both abstinence-only peer support groups that historically were considered treatment. However, we know that 12-step groups are not formal treatment, right? They're not the evidence-based harm reduction type treatment that we offer now, but there is a very important role for these 12-step groups for the individuals who find them helpful, because offering patients that camaraderie with a peer community supportive of their recovery can be essential. If their entire social support system is using substances and you want to meet some new sober friends, well, AA is a great way to do that and to surround yourself by others who are like you and are wanting to get better. So for some people, these kinds of groups alone can be sufficient for maintaining recovery, but the overwhelming majority, this is not enough, right? It's important to remember that these groups are self-selected. So the individuals who benefit from them are the individuals who attend them. All of the other individuals with substance use disorders do not attend them because they do not benefit from them. One opportunity to reduce stigma is actually through the use of programs like AA. So this was a paper that I published with colleagues where we did a study at our institution with our medical students. We actually had them attend an AA meeting in our community, an open meeting. And the AA groups in Omaha have been welcoming medical students for many years and actually really like this sort of project that we have with them because they enjoy getting to educate the students. And we had the students each attend an AA meeting, any open AA meeting, and we had them write a reflection paper about the experience. Just 2 pages, double-spaced, not anything, a novel, but we had them answer several prompts, particularly, what were your expectations when you went to the meeting? What preconceived notions did you have when you went to the meeting? And were those true? Did they turn out to be true? How do you feel now after having attended the meeting? So we took all of those papers from an entire academic year and we analyzed them qualitatively through a thematic analysis. And what we found was that stigma was reduced. Attitudes were changed simply by attending an AA meeting, engaging, and then reflecting on the experience, right? Truly thinking about it. We found that early exposure to patients in recovery from medical school can actually help to decrease stigma among clinicians later on, because reflecting on the experience is one way to decrease stigma, as we found in our study. Now, this can be done not only with medical students, but really with any individuals who are in a community where the AA groups are supportive and welcoming of something like this. But this is just one opportunity to reduce stigma. So evidence-based services, they are designed to enable an individual to reduce or eliminate, again, abstinence is not the requirement, alcohol and other drug use. You want to address the associated physical or mental health problems. And ultimately, you want to restore the patient to maximum functional capacity, right? We want these individuals to be living their best lives, to be engaged with their families, to have shelter, to have steady employment, to be contributing members of society. And if they do that while having a drink every night, who am I to argue, right? It's not up to me to say how they should and shouldn't live their lives, but it is up to me to help them meet their goals. When we look at other chronic medical conditions, like diabetes, hypertension, asthma, all of these have been likened to substance use disorders as a chronic disease model. This study amazingly was done in the year 2000, and it holds 1000% true today as well. So what they looked at were individuals who were receiving the evidence-based treatment and who had rates of relapse, meaning for substance use disorders, relapse was a sustained return to substance use. So not like a one-time slip, but a sustained return to use. For the other conditions like diabetes or hypertension, they looked at your disease severity and that it became so severe you needed a new medication to be added to your medication regimen. So maybe you were already on a blood pressure medicine, you needed another one, or that required hospitalization. So a hyperglycemic coma or something like that for diabetes. And what they found was that substance use disorder rates of relapse are actually lower than some of these other chronic medical conditions when they're receiving evidence-based treatment. And yet we have this negative stereotypical image that, you know, these patients never get better and it's a revolving door, when the reality says it's not true if they actually get the treatment that they need. This is my favorite slide, and it always has been, because I think it illustrates quite nicely why we look at addiction differently. Because both chronic diseases require ongoing care. Here's a comparison with hypertension, right? High blood pressure is something many Americans experience and go to their primary care provider for. So before they get any kind of treatment for it, their symptoms are high, right? The severity of symptoms, which is what the bars show. So pre-treatment, your symptoms are going to be high, right? Well, then you go see your primary care provider and they prescribe you an antihypertensive or a blood pressure medicine. You start taking your blood pressure medicine and your symptoms go down, right? Your blood pressure stabilizes and becomes within normal range while you're taking the medication that your doctor prescribed to you. Well, say you then stop that medication for whatever reason. Well, your blood pressure is going to go right back up again, right? Because you're no longer treating it. Well, that's exactly the same with addiction, right? Before you seek treatment, your symptoms are high, right? You haven't gotten any help yet. While you're getting help in treatment, your symptoms go down because you're in treatment and they're getting appropriately treated. And then say you just abruptly stop treatment. This is exactly what happens when we send people away to rehab for 28 days and then they're discharged after completing the program. And then what? They're not in treatment anymore. So what's going to happen? Well, their symptoms are going to go right back up again, right? It's a chronic disease. We can't expect it to just magically go away. And yet that's exactly what we expect with substance use disorders. So to summarize, stigma reduction, is it really so novel? Normalizing substance use disorder as a chronic disease and employing a chronic disease care model, much like for other chronic medical diseases like we talked about. Meeting patients wherever they are at on their recovery journey. And that is what harm reduction is. And utilizing non-judgmental, clinically accurate language when we talk about individuals who have substance use disorders, something that is within each of our powers to do. When we do all of these things, we see that the system impact can be profound. For every $1 that we spend on substance use disorder treatment services that are evidence-based, we save $4 in healthcare costs and $7 in criminal justice costs. That's a lot of money, but it requires the investment of that $1, which oftentimes organizations, governments are strapped for money, budget cuts, all of those things we hear about and read about in the newspapers, and mental health and substance use disorders get overlooked. And we don't invest that $1. And so then we don't get those $4 and $7 back. So the take-home points are that stigma is universal. It impacts all of us, and it impacts patient care or lack thereof, right? Only 1 in 10 actually receive the care. Addiction is a treatable medical illness like hypertension or diabetes. And your words matter. And you, every single one of us, have the power to decrease stigma simply by changing the language that we use to talk about addiction. And with that, I will conclude. I keep calm and don't judge. And I think we have a question and answer session out. Yep. Okay. Lori will tell us about it. Well, thank you so much. And I look forward to chatting with all of you out there.
Okay. All right. So as you exit, you're going to be handled a folder. And in the commons area, grab a water, grab a snack, and then find a table with that same color on it. And then you're going to be going through discussion questions with your table guide. And I want to just make sure that you visit the vendor booths before you leave. Follow MEADA on Facebook. I can't say that enough. And if you want to have continuing education credits or anything, make sure that you sign up on one of the sign up sheets, either at MEADA booth or at each one of the discussion tables. They have, we have, sign up sheets at every single table. So thank you so much for attending. I appreciate those of you who are online right now and in person. And then of course, the people that are going to see the recording, which if you would like access to that, make sure to make that known when you sign up on one of those sign up sheets. So the Drug-Free Communities Grant, it does have two main goals: increasing community collaboration and reducing substance use among youth. Part of that is building capacity. And I believe that's part of what we did today. And it was a really good way for drug-free communities to make its mark in the Wright County area. And we're very, very happy to have the Drug-Free Communities Grant. It is a 5-year grant. And if you are at all interested in knowing more about what MEADA is doing or the Drug-Free Communities Grant, please let me know. During the question and answer, Dr. Alona will be walking around, as will I. And so if you have any questions that come up at your table and you're kind of stumped, that's what she's here for. So she's able to answer those in the commons area. So thank you very much.